our 67th Blue Heads virtual seminar. Blue Heads virtual seminar is a platform that allows healthcare professionals to discuss current management updates of different health-related topics for better patient care. And this platform is brought to you by Blue Health Ethiopia, a medical consultancy company founded by medical doctors and a computer engineer, and we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge and preventive medicine. And I'm your host, Dr. Hienot Adela, a general physician and first aid trainer from Blue Health Ethiopia. Today, it's an honor having Dr. Abdulkadir Mohamedsaid here with us to have a presentation on oncologic emergency and pediatrics. Dr. Abdulkadir Mohamedsaid is one of the leading pediatric hemato-oncologists when it comes to pediatric hemato-oncology service in Ethiopia. He is currently a consultant pediatric hemato-oncologist at Addis Ababa University Tukur Ambassa Comprehensive Specialized Hospital. Dr. Abdulkadir is the president of Ethiopian Society of Hematology and Oncology and is a member of the International Society of Pediatric Oncology. Dr. Abdulkadir, the stage is all yours. You can begin.
Thank you. Just what I want to mention some of the things that ESHO is involved with. We are working on the CPD with Blue Health consultancy, and ESHO has agreement with Blue Health. So this will be the first CPD which is provided by the ESHO. Dr. Abdulkadir has introduced me, and I'm the current president of the ESHO. The Ethiopian Hematology Society is the society which includes the members are pediatric hemato-oncologists, clinical oncologists, adult hematologists. All the hematologists and the clinical oncologists are under one umbrella in the Ethiopian Hemato-Oncology Society. There is no other society which represents oncologists and hematologists. And it was established in 2019 now. It will conduct its fourth annual conference on February 24 and 25, 2024, and we are glad those who are interested to join the conference. Thank you, and I will proceed to the presentation. So, oncologic emergency is one of the most causes that lead to death of the children. So, if you are not handling the oncologic emergencies, handling of the underlying malignancy is not that much so important. So, oncologic emergencies are life-threatening conditions, and most of the patients die due to oncologic emergency. So we have to have an overview, a picture, and the clinical presentations, how the patient is present during the oncologic emergency. This is my presentation. So as a general rule, to handle the patient, one thing that we have to know is we are treating the patient, not treating the cancer. I raise this issue because most of the time we focus on the cancer, management of the cancer. But we have to take the patient as a whole, and we have to think about the emergency conditions, and we have to follow by the patient. So your patient is your guide. This is not cancer, but the patient condition is the one which guides you how to handle the oncologic emergency. The second thing that you have to know as a rule is better management needs better assessment. So if your assessment is not correct, you will end up with a wrong assessment, and the management will be also wrong. So you have to have better management needs better assessment, and the evaluation assessment should be thorough, and you have to detect all the possible findings and from the history and the physical examination. So it is because once you assess the patient, you can anticipate what the oncologic emergencies that the patient can develop. This is because prevention is more important than treating the complication. Once the patient develops complication, it will be very difficult to treat the patient. I will discuss this when I present each cases. So it's better assessment will lead you, will guide you the things that you should anticipate on the follow-up of the patient. So the third rule, you have to remain confident and reassuring. So if you are not confident and if you are panic when the patient presents with emergency, it will be very difficult for the parents to convince and to reassure them. So you have to be confident on what you are going to do and you have to reassure the parents. So the objective of the presentation is one thing, the first objective is you have to recognize common emergency conditions in the pediatric oncology patients. So there are a lot of emergencies, but I'll focus on the most common. If I have time, I'll add some more. You have to identify the hallmark signs and symptoms of common oncologic emergencies. So the signs and symptoms which can lead us to a specific oncologic emergencies are important and you have to know that. The other thing is you have to understand the important initial steps in the treatment of oncologic emergencies. So if you miss the initial step, the patient may pass away. So it will not be good. So always you have to know what you have to do as an initial step when you see a patient with oncologic emergency. The fourth objective, you have to articulate appropriate medical interventions for common oncologic emergencies based on assessment findings. These are the things that I am going to discuss. So when we see the classifications of oncologic emergency, we can categorize based on the systems. One is, it can be metabolic emergencies, hyperkalemia, hypercalcemia, hypernatremia, tumor lysis syndrome of inappropriate ED secretion. All these are related to metabolic emergencies, and the others related to cardiovascular system emergencies. Patients can present with pericardial effusion, cardiac tamponade, prevena cava syndrome, and in the GI system, typhlitis, perirectal abscess, pancreatitis, and in the GI, you can see the other classifications on the slide also. So this is one type of classification based on the category and the system. The other is on the time point of emergencies. So on the time point of emergencies, so the tumor oncologic emergency can be before the treatment of the patient, so or it can occur during the treatment of the patient. Okay, so we have to consider what are the conditions that the patient will develop during treatment. So we can anticipate and we can manage and prevent the development of oncologic emergencies during treatment. The other is when the patient presents, they can present with oncologic emergencies. We have to act fast. So the first thing in common oncologic emergencies, tumor lysis syndrome. Tumor lysis syndrome is a result from rapid cell breakdown. And when the cells are rapidly break down, they release the intracellular content. And these intracellular contents are most of the time nucleic acid in the form of uric acid, phosphorus, and potassium in the circulation. So there will be high potassium level, high phosphorus, and high uric acid level in the serum. And due to the high phosphorus level, the calcium level will be low, and hypocalcemia can be a secondary effect. So these are the things that the patient will have when they develop tumor lysis syndrome. And this can happen before treatment, or we call it primary or spontaneous TLS, or it can be secondary to treatment. For example, if patient who has leukemia, when you start treatment, there will be days of cells, and the release of this intracellular components will be high, so the patients will go to TLS. So this is the secondary or treatment-related TLS. But this can also happen as a primary before the treatment starts. There are risk factors that predispose the patient for tumor lysis syndrome. One is large tumor burden. This means, for example, if a patient has with Burkitt leukemia or Burkitt lymphoma, if the patient has huge abdominal mass, the number of cells will be high, so there is a high burden, tumor burden. When you start treatment, you will destroy the malignant cells, and these cells release the intracellular components which I have mentioned earlier, and they will develop TLS. The other is leukemia. If the patient has leukemia with high cell count, this patient is also will be at high risk of developing TLS. The other thing that we have to consider is intravascular volume depletion. So when there is dehydration, the intravascular volume also decrease, and this will increase the intracellular full metabolite, electrolytes and other metabolites which are found in the intravascular space. So this is one. The other thing is, if the patient has before the development of the malignancy, if the patient has renal problem, this is one of the factors that leads the patient to put high risk for TLS, because uric acid is excreted through the kidney. So if the patient has kidney problem, the patient will not be able to excrete the uric acid. So these are the patients that are at high risk. So what are the metabolic failure of syndrome? Just as I mentioned earlier, there will be hyperuricemia, the uric acid level will be high, the potassium level will be high, and the phosphorus level will be high. So if the phosphorus level is high, the calcium level will be relatively low. So these are the criteria to diagnose the tumor lysis syndrome. So we classify tumor lysis syndrome like laboratory TLS and clinical TLS. So if the patient has two of these criteria, the patient will have laboratory TLS. So, but clinical TLS, if the patient develops renal failure, cardiac abnormality, seizure, CNS manifestation, the patient will have a clinical TLS. So it is important to know to act when the patient is at laboratory TLS level before the patient develops clinical TLS. The best is, if you know the risk, if the patient is at high risk of developing TLS, it is better to prevent the development of laboratory TLS. So if the patient doesn't have a laboratory TLS, the patient will not develop clinical TLS. So these are the lab findings that are used as a criteria. So if the uric acid level, the potassium, the phosphorus, and the calcium levels are the top three, uric acid, potassium, and phosphorus, are below these limits, the patient can be diagnosed as having TLS. So elevated BN creatinine and elevated WBC, LDH, these are the other risk factors that predispose the patient for the TLS. So if the patient has secondary renal failure, so you do TLS, we call it as clinical. You can clinical TLS. So the clinical manifestation, the patient can have nausea, vomiting, diarrhea, ascites, all that are mentioned in the triac column are the signs and symptoms of TLS. So when you come to evaluation, the first thing you have to do CBC. CBC can tell you whether the patient has high cell counts, which is one of the predisposing factor for TLS, and the uric acid level, the creatinine level also important. If the uric acid level is high, the patient is at high risk of developing TLS. So we need two criteria. For example, if the patient has uric acid of 10 and the other parameters are normal, this patient doesn't have TLS, but it is a high risk for TLS, so we have to prevent the development of laboratory TLS. The other is ESHO. We can see the potassium level if it is greater than 6 milliequivalent per liter, or if there is ECG changes that indicates hyperkalemia. The other thing, pre-BCL ALL with low WBC and minimal hematology lab can be monitored every 8 hours. This is because tumor lysis can happen during treatment. So once you do the tumor lysis markers, and if it is normal, when you start treatment, the patient can develop treatment-related TLS. So it is good to follow the patient. We cannot put the patient on chemotherapy and leave the patient without monitoring the development of TLS. So patients after treatment, they can develop TLS. So the first 72 hours, it is mandatory to follow whether the patient will develop laboratory TLS or clinical TLS. As I mentioned earlier, Burkitt's lymphoma is one of the high risk, one of the conditions that prepare the patient for high risk. So always do tumor lysis markers and decide whether the patient has TLS or not. So if the patient has 2 or more marker positive, it is TLS. If the patient has 1 marker positive, it is a high risk for TLS. So we have to follow the patient properly, and I'll come later to the management. We have this case. So a 15 years old patient with a history of G6 glucose 6-phosphate dehydrogenase is diagnosed with pre-BALL, acute lymphoblastic leukemia. At presentation, the WBC is 160,000 per microliter. With 90% lymphoblast, hemoglobin level is 7.5 gram per liter, and the platelet level is 10,000. His electrolyte and renal functions are normal. The uric acid level is 11, and the LDH is 1,500. Remission induction chemotherapy is planned. So, is this patient at high risk of developing TLS, or does this patient has TLS? You can. So, what is the risk of tumor lysis syndrome? It is very high risk. So, but this patient doesn't fulfill the criteria to diagnose the patient as having TLS because the electrolytes are normal. That means the potassium, the calcium, the phosphorus levels are normal. So we need 2 criteria to diagnose laboratory TLS. This patient has 1 criteria, which is high uric acid. This tells us the patient is at high risk of developing TLS, but this patient doesn't have clinical as well as laboratory TLS because the renal function is normal. So, what is the optimal treatment for preventing TLS? So, this patient is at high risk for development of TLS. He doesn't have TLS. So, the best is always to prevent the development of TLS, laboratory TLS. If the patient develops laboratory TLS, it can progress to clinical TLS. So, we have to prevent the TLS. How to prevent the TLS? You can put your answer in the chat box. Hydration. Most important is you can put him for hydration. Okay, you can put the patient on hydration. So the hydration means we have to give him more than 1.5 or 2 times the maintenance. So we have to overhydrate because the uric acid can be washed out, and the patient can be safe before developing renal failure. The other thing is you can use rasburicase or allopurinol. Rasburicase can be used in a patient who has clinical TLS, but you can use allopurinol to prevent further use. The other is urine alkalization. It is not mandatory currently. So, the risk dependent. So, this patient has more than 100,000. So, it is high risk. So, hydration is the most important. So, hydration is the most important. You have to give hydration. You can use allopurinol, but in a patient who has clinical TLS, you can use rasburicase. But always the most important is hydration. This is just to show you where it talks allopurinol prevents the production of uric acid. So there will be accumulation of xanthine in the back. So the best is to use rasburicase. If the uric acid is very high, then the patient has a high level of uric acid, just to destroy those who are produced, because allopurinol doesn't affect the uric acid which is produced already. So the best is to use rasburicase if the patient has high risk TLS, laboratory TLS, or clinical TLS. Otherwise, you can prevent with hydration and allopurinol. So the other complications with TLS, we see hyperkalemia. It is just to refresh. We can use diuretic agents. We can use calcium gluconate and insulin with can be given so that with glucose, so that the potassium in the intravascular space can shift to intracellular. The other is after hyperphosphatemia, we can use ammonium hydroxide, the dose is mentioned there, and hypocalcemia is if the patient develops hypocalcemia, the thing that you have to consider is we have to be very cautious unless the patient has signs of hypocalcemia. We shouldn't give the patient calcium, because if you see if you multiply phosphorus and calcium value, and if it is greater than 60, the patient can develop calcinosis. So the calcium and the phosphorus multiplication is important. If the patient doesn't have clinical TLS, by treating the hyperphosphatemia, the calcium can be corrected. We can follow properly the patient, and that can be corrected. If the patient is clinically symptomatic, we can use with cautious calcium. So the patient can have renal failure. So these are the indication for dialysis. Volume overload, which is refractory, hypertension refractory, if the persistent symptomatic hyperkalemia, these are the things that you have to consider for dialysis. So if the patient has clinical TLS with renal failure, you can try conservative management. If the conservative management fails, you will go for renal tube replacement therapy. That is for. So I will be relatively fast now. The other is hyperleukocytosis. The definition is greater than 100,000. So the most common cause of the most common pathology that we encounter when the patient has high cell count is leukostasis. This leukostasis can occur in the capillaries, and due to increased blood viscosity, and there will be microthrombi that induce inflammation and thrombosis, and also bleeding. So patients with hyperleukosis, they can have bleeding also. So cerebral hyperviscosity, CNS hemorrhage or stroke can be there. Pulmonary leukostasis, pulmonary hemorrhage or alveolar damage can detect, and the renal failure also can be due to glomerular infiltrations and leukostasis. So the end organs also can be damaged. So based on the organ affected, the patient can have that clinical manifestations. So this is the other case related to the 6-year-old child with TLS was 80,000. The total leukocyte count was 80,000. Hemoglobin 8.5, platelet count 10,000, and given a single donor transfusion. He was transfused. Bone marrow was done and revealed AML, monocytic AML. 24 hours after admission, he developed high-grade fever and progressive tachypnea. CT showed pulmonary infiltration. The most possible diagnosis patient, let's go on. Pulmonary infection is possible because the patient has fever, okay? We cannot ignore infections. Pulmonary causes also is possible. So monocytic infiltration is also possible because monocytes are relatively high and there will be adhesion of the cells. Transfusion-related acute lung injury, yes, because the patient was also transfused, and all are possible diagnosis in this patient. So the management is similar to that of TLS, because hyperleukocytosis can predispose the patient for TLS. So you have to handle the hyperleukocytosis, and most commonly, as I mentioned earlier, you can hydration is the most important, allopurinol. But there are other modalities that you can use, but the most important is IV fluid, allopurinol, and you have to reduce the cell count by giving hydroxyurea, or you can give steroid or elastoprigine. There are different modalities that can be used to reduce the cells. So this is just to see, for a male, the risk will be high with a cell count of 50,000, greater than 50,000. The previous example, it is 80,000. Because relatively the cells are big, there is high risk of leukocytosis in a patient with AML. In ALL, the risk is relatively low. So the cell count, we need more cell count to see the leukocytes. Complication, bleeding, which is the one which I mentioned earlier, can be a complication which is related to leukapheresis. So it is not recommended in a patient who has APML, which is a AML type 3. Type 3. The other is superior cava syndrome. Okay, we call it sometimes mediastinal syndrome, depending on the degree of affection. So superior cava syndrome refers to the symptoms that occur from compression or obstruction of the superior vena cava, usually caused by either thrombosis or anterior mediastinal mass. It can be due to the mass effect, but also it can be by thrombosis. If the patient has central line, this central line can induce the coagulation cascade, and the patient can develop thrombosis. So the thrombosis can be one of the causes. When there is compression of the mediastinum, the trachea, the patient is termed as having superior mediastinal syndrome. Superior mediastinal syndrome includes compression of the trachea. So these patients can have a problem with airway obstruction and difficulty of breathing. So pathogenesis, this is what I have mentioned earlier. So the most common primary cause of superior vena cava syndrome in children, mediastinal mass. So patients can present with intrathoracic lymphoma. Patients can present with teratomas, lymphomas. So these are the things. But if the patient has central line, they can still have central line related thrombosis and superior vena cava syndrome. The presentation, edema of the upper way, the upper part of the body with puffiness for the face. So the hallmark sign is upper body edema and venous engorgement. Symptoms are typically aggravated when the patient is in supine. So in patients who has superior vena cava syndrome, it is not allowed to examine the patient in supine position. The patient can die while you are examining due to respiratory failure. So even investigations are not, you should not be aggressive. CT should not be done in such patients. You can do erect chest X-ray to see whether there is a mediastinal mass or not. So when the patient is stable, you can do more investigations. Otherwise, sudden respiratory arrest can occur in the patient when you put the patient supine. I know patients who passed away. Just one of the physicians asked the patient to lie down for examination, and the patient passed away. So don't let the patients to go to supine position and for examination. So you have to examine the patient in sitting position. So this is one of the cases. A 10-year-old female patient presented to emergency with respiratory dishoarseness, edema of the face, and with a platelet count of 30,000. CT showed large mediastinal mass, which is 8 by 10 by 5 centimeters. What is the most possible diagnosis? How to approach this case? Okay, all the answers are possible, yeah? So lymphoma, it can be lymphoma, it can be thymoma, it can be anything, but you can call, there are anterior mediastinal mass differentials, okay? So the possible most common is in such patients is lymphoma, it can be also germ cell tumors, okay? How do you approach this patient? How do you diagnose this patient? So the patient should be kept in sitting position. So these are the things that you have to consider. These are germ cell tumor, lymphoma, parathyroid lesion, substantial thymoma. These are possible differential diagnoses that can be seen in the anterior. So the diagnosis should be made in the least invasive manner possible. So, for example, you can do CBC. If the patient has CBC with a cell count of 200,000, and if the chest X-ray showed mediastinal widening, you can consider T-cell lymphoma or T-cell leukemia. So by doing CABC, you can diagnose. If the patient has cervical lymphadenopathy, you can do FNAC from the cervical lymph node, or you can do local, using a local anesthesia, you can do bone marrow aspiration. So you should not be aggressive. If you are aggressive, the patient can die due to the respiratory. So you have to use less invasive procedure for the diagnosis, and once you have a definite diagnosis, you can go for treatment. So, for example, if it is a suspected T-cell, I can start T-cell treatment for the patient, but most of the time what we do is we give the patient steroid just to reduce the edema or the swelling. So chest X-ray, the other things that you have mentioned can be seen. Okay. Initial management with medicinal mass should focus on the airway and circulation. So this is ABCR. You have to stabilize the patient before any further. So whenever we see a patient, we have to put the patient in sitting position, oxygen, and we have to be, if the patient is dehydrated, we have to hydrate the patient. We should start immediately steroid for such patients, and sometimes based on the clinical manifestation, even we can start chemotherapy immediately to save the life of the child. And side by side, we can go for workup of the patient. Use emergency systemic steroid and chemotherapy in suspected leukemic and lymphomatous masses. So just you can start chemotherapy if you have strong evidence, and you can, after taking the sample side by side, you shouldn't wait to get the result. Just go for treatment. If there is central line which is related with thromboembolism, just you can start anticoagulant and you can remove the central line. So the most important thing in the superior mediastinal syndrome or superior vena cava syndrome, just go for life-saving procedures. Go put the patient on oxygen, sitting position, start steroid or chemotherapy based on the most likely diagnosis, and do less invasive investigations to confirm the diagnosis. Don't wait to get a confirmed diagnosis. You lose the patient. If you lose the patient, it has no value for the to get the definite diagnosis. So always act the emergency cases. This is just to assess the airway. If there is airway obstruction, always don't do biopsy, okay? Unless it is a patient is low risk. If it is high risk, always avoid anesthesia. The patient can die during the procedure. The other emergencies, oncologic emergencies, spinal cord compression. The spinal cord compression can occur due to the mass effect, any mass in the retroperitoneal space, in the posterior mediastinum can compress the spinal cord. The other is the vertebral can collapse due to lytic lesion. For example, neuroblastoma can metastasize to the vertebral bone and the vertebral bone can collapse. Or during lymphoma is a possibility that collapse of the spinal, the vertebra. This can lead to compression. The other is the pressure effect. All this can lead to cord compression. So it is an oncologic emergency, and you have to act immediately. If the patient develops acute paralysis, acute weakness, it is wise to decompress the pressure. I'll come to that in the next slides. So as you can see here, the mass can compress the spinal cord. So these things which I mentioned earlier, neuroblastoma, tissue sarcoma, lymphoma, germ cell tumor, all this can affect the spinal, the vertebral column, or the mass can extend to the to the subcarotid to intravertebral column foramina. It can go there, so it can compress the spinal cord. So clinical presentation, they can have neck pain, pain due to compression, acute weakness in the lower extremities, sensory deficit, bowel and bladder dysfunction, and refusal to walk because of the pain. They can have ataxia depending on the site of the lesion, the compression. So any patient who has acute, it is wise to start steroid, because steroid can compress, can reduce the edema, and you can save the child. Then, because the neurons, compression of the neurons, if it is prolonged, the patient can have permanent paralysis. But if you start early, there is a possibility that the patient regains function. So for this purpose, you have to evaluate the patient properly, and you have to know when the patient develop also the paralysis. So detailed neurological examination is mandatory. So you may miss, for example, if you are not doing the proper physical examination, so you may miss the power. The patient may have a power of 4, and you may overlook that the patient doesn't have any weakness. So it is better to do a proper examination. The other thing, tumor markers, is important, because if the patient has high alpha fetoprotein beta ICG, I can consider germ cell tumor. If VMA-HV is high, I can consider neuroblastoma, because it is important for the further management. Some tumors are sensitive for radiotherapy, so I can give radiotherapy. Some cells are sensitive for chemotherapy, I can give chemotherapy to save the compression of the further damage of the spinal cord. So early diagnosis and treatment are essential to decrease the risk of permanent neurological deficit. In such cases, don't wait for a definite diagnosis. Just start high dose steroid, and based on the possible diagnosis, you can go for chemotherapy, emergency radiation, and surgical decompression via laminectomy, depending on the type of the tumor. If the tumor is not sensitive for chemo and radiation, surgery is the most important to decompress the lesion. So the factors affecting, you can consider the age is important, onset is important also. And then this is one of the case, okay? 1 year old child presented, 1 year old child presented by back pain and lower limb weakness of 3 days before admission. MRI showed large paraspinal mass with spinal cord compression, and bone marrow showed infiltration by non-hematopoietic stem cells, and scheduled for CT guided biopsy. What will be the best treatment option for this patient? Okay, I'll come to that. Second question. This is the second case. A 16-year-old female patient presented by progressive bilateral lower limb weakness, started from 10 days. The previous was 3 days, this is 10 days. On exam, she has multiple coagulated pies. MRI study showed large paravertebral mass with spinal cord compression. What will be the best treatment for this patient? Okay, for this patient, it will be D. D is the best, because this patient has coagulated spots, and as well as this patient has most likely sarcoma, which is not sensitive to chemotherapy. But in this case, in this patient, the most likely this patient has neuroblastoma, which is sensitive to chemotherapy, and steroid and chemotherapy can be used. But depending on the setup, the other modalities can be used. But most of the time, we have to start immediately steroid, and based on the degree of compression, we can go also for decompression with surgical. Don't waste much of time to reach the diagnosis. Dexamethasone can be given, and this can reduce edema, decrease the inflammation, and stabilize the vascular membrane. So the patient can be saved from permanent disability. Emergent consultation with neurosurgery is important because laminectomy can be done in patients who are not responding for chemotherapy. Chemotherapy should be recommended as first step of treatment of known tumors. As I mentioned earlier, those who are sensitive for chemotherapy, you have to go for chemotherapy. But sarcomas, which are not sensitive, for example, if you take lymphoma, even with steroids, it can melt. The mass can melt, so you can go for. But sarcomas is very difficult to treat them with chemotherapy because it will take time. So in such patients, you can start the steroid, as I mentioned earlier, and put the patient on laminectomy because you will decompress the spinal cord, and you will have time for the effect of chemotherapy because it needs time for the action. This is an approach you can. So the other is increase CP, increase intracranial pressure. You know, because the intracranial pressure, there are three organs or three compartments in the brain. One is the brain, the other is the vascular structure, the third one is the CSF. So any distortion in the imbalance in this are the one that leads to increased intracranial pressure. Okay, so when there is increased cerebral CSF fluid, there can be ICP. When there is increased flow, when there is tissue brain increases, like a brain tumor, the patient can develop increased intracranial pressure. So it's important to consider this also as oncologic emergencies. Risk factors are CNS tumor, bleeding. In a patient who has, for example, severe thrombocytopenia, they can bleed intracranial. So these patients can have shunt infection, head injury. All these are potential risk factors for ICP. If it's not handled properly at early stage, the patient, it can progress to severe case and the patient can die due to herniations. Early signs are morning headache, lethargy, and fatigue. So patients early headache and vomiting without nausea, most of the time can be a hallmark. Rarely nausea can occur, but most of the time there will be no nausea. They can vomit without nausea in early morning. So poor academic performance, change of consciousness level. These are early signs. So if the patient has lethargy, it's wise to consider increase intracranial pressure. Otherwise, when it is late, you know the triads, okay? Decrease heart rate, increase blood pressure, and the other regular breathing can come. But the difficulty is in infancy, because in infancy, the patient signs of increased intracranial pressure may not be easily detected unless you do a serial measurement of the head circumference, because the sutures are not fused. So there will be a space for accumulation of increased mass or the increased CSF fluid. So it will be sometimes difficult. So it is always considered to ask the parents whether there is increment in the head circumference and change in the behavior. So these are the things that we have to consider. Approach, history and assessment is vital. Vital sign is important because the patient can be bradycardia and hypertensive, and the type of breathing can be irregular type of breathing when the patient's condition deteriorates. So vital sign is important when you have to follow the vital signs. So as usual, dexamethasone is a drug of choice. Mannitol can be used. If the patient has convulsion, we can use anticonvulsants. Okay, if it's not controlled, you can sedate the patient. If there are other predisposing factors like shunts, CVD, we have to manage them. And if there is a tumor, after stabilization, we have to remove the tumor. Okay, the early signs of increased intracranial pressure generally involves changes in, what is your answer? Okay, level of consciousness, okay? The others are, you are caring for a female patient who has advanced diffuse intrinsic brain stem glioma. She is unresponsive but otherwise stable. You note which of the following trends in vital sign if CPI is rising. Okay, it will be B. Okay. The other is cerebrovascular accident. Okay, this is due to, this can be secondary thrombocytopenia or thrombosis, and it can be related to the ICO treatment related with elastosparaginase. These are the clinical impaired vital sign, increased ICP, seizure, this level of consciousness, and neurological deficit. This is MRI that shows this is obstruction with a thrombosis and ischemia. So as usual, you have to do a proper physical examination, and if there is emergency, ABC, you have to act. Okay, airway, convulsion, you have to manage the convulsion. Seizure, if there is seizure, you have to control the seizure, and after stabilizing, you have to go for a definite diagnosis. So because the time is going, I will jump this one. I will go to the other slides. Okay. The other most important is neutropenic enterocolitis. So in a patient who has chemotherapy, the patient can have neutropenia, and these patients are at high risk of developing necrotizing colitis or ileocecal syndrome or typhlitis. So these patients will develop damage to the mucosal layer, and this mucosal layer can lead to leakage of the bacteria, or it can be a focus for injury for the patients to develop infections. So the risk factors for neutropenic enterocolitis, one is severe neutropenia. When we say severe neutropenia, the absolute neutrophil count less than 500. So in a patient who has severe neutropenia, this is one risk. There are patients with have high risk for patients who has high dose cytarabine chemo drugs. So high dose cytarabine patients, for example, AML patients, these are at high risk of developing typhlitis. So patients who are on induction, patients who has relapses, patients who has intensive chemotherapy are at high risk of infection. So there will be mucositis and inflammation and distortion of the mucosal system, starting from the oral cavity to the anal regions. So all the GI tracts can be affected. The most common organisms, Clostridium, Pseudomonas, and even Staphylococcus infection, Staphylococcus aureus, and fungal infection can be there. But the fungal infection is not common. But if the patient is responding for the common bacterial infection, it is wise to consider also fungal infection. A 13-year-old patient with AML is treated with induction therapy. On day 18, he developed fever, bloody diarrhea, and right lower abdominal pain, followed by a few hours later by acute abdomen. Can neutropenic enterocolitis be prevented? Best treatment options. What is the role of surgical intervention? Early diagnosis is the most important. As I mentioned earlier, in a patient who was suspected that they will develop neutropenia, for example, severe neutropenia, develop paragal, those who are suspected of developing severe neutropenia, we can give GCSF and the patients may not develop severe neutropenia. So we can prevent by giving, but no, you cannot always prevent the development of neutropenia, and patients can develop. The most important is you have to have diagnosis early before the patient develops complications. So when the patient develops abdominal pain and fever, you have to anticipate that the patient can have typhlitis or enterocolitis, and you have to act. Fever and abdominal pain with or without diarrhea in neutropenic patient is most likely typhlitis. So you can confirm using ultrasonography or CT scan, and you have to decide based on the ultrasound findings. If it is left untreated, the patient can develop perforation, and once the patient develops perforation, it will be very difficult to manage, and at that stage, surgical intervention can be also an option. So treatment, power rest, okay? So in case of TLS, we said hydration. In case of TLS, nothing should be given per os. So the mucosa should be given for time for regeneration. So fluid restriction, fluid resuscitation, I mean, because the patient can have diarrhea and second, third space sequestration, and you have to manage the patient properly. NGSU should be inserted, and it has to be sucked out, and through section you have to keep the fluid balance properly. So any ongoing loss should be replaced. If it is possible, parenteral nutrition should be given. In our setup, it's very difficult because it's not a common practice and patients is not getting parenteral nutrition. So early surgical consultation is important. In a patient who has perforation, patients may need surgical intervention. Some patients should be treated with broad spectrum antibiotics because these are multibacterial infections. Okay, this is not only one bacteria. There are as anaerobes, gram-negative, gram-positive can be there, even including fungal infections. So patients who has protracted neutropenia for greater than 7 days and profound neutropenia less than 100, NDC less than 100, neutropenia, protracted neutropenia greater than 7 days. These patients are at high risk of developing neutropenia. So always you have to consider patients having neutropenia with a fever, neutropenic fever. One most common site is one of the typhlitis. So in a patient who has neutropenic fever with abdominal pain, you have to consider. So complications can be hypotension, so weak pulse. So these patients can develop sepsis and septic shock. If the patient develops sepsis and septic shock, it is very difficult to salvage the patient. So it's better always to consider typhlitis at early stage and to manage the patient properly before the patient develops other complications. A major clinical manifestation of sepsis in an infant is respiratory distress, okay? Because most of the time we expect that the patients will have hypotension, poor feeding. These are late manifestations. So if the patient has an infancy, if the patient has respiratory distress, it's better to consider that the patient is going to shock. and sepsis, and you have to act immediately, and you have to look for the focus. The most common focus is the chest and the GI. Okay. Early recognition is important for intervention. So if the patient is in warm shock, it will be easy to reverse the shock. If the patient develops septic shock, it is very difficult to manage because the patient will need vasopressin, even ICU admission. So the best always when you see a patient with diarrhea and abdominal pain and fever, you have to suspect that the patient will have typhlitis and be aggressive in handling the patient by fluids, by giving more fluid, by putting the patient in EPO and following the patient and putting the patient on high broad spectrum antibiotics. So this is I will jump this one. Thank you for the. If you have any questions, you can raise questions.
Okay, thank you very much, Dr. Abdulkadir. So participants, if you have any questions regarding the topic, you can write them down in the chat box and doctor can address those. So, doctor, there is one question. Why hypothermia in patients with increased ICP? Yeah.
So, because it is increasing, one of the thermoregulatory centers in the brainstem. So patients, if they have increased intracranial pressure, the brainstem function will not be proper. There will be dysfunction of the brainstem, so the thermoregulatory center will be affected. So patients can have hyperthermia, hypothermia because of the dysregulation.
Okay. The other question is Johannes Berhe. When should we start hydroxyurea for hyperleukocytosis?
It depends on the type of the tumor. For example, in a patient who has greater than 1,000, for all patients, you have to start hydroxyurea. But for example, a patient who has lymphoblastic lymphoma, lymphoblastic lymphoma or lymphoblastic leukemia, you can start steroid rather than starting hydroxyurea because they can respond with steroid. If there is no response for steroid, you can add hydroxyurea or elasparaginase. The most important thing is when it depends on the type of the tumor. AML, you have to reduce fast because of the large size and they can obstruct the capillaries and there is a high risk of leukostasis. In lymphoma, in lymphoblastic leukemia, you can use steroid and you can have time. I have showed you on the slide the risk depending on the number of cells. In the previous slide, you can check on that.
So the other is Asafa Sunta. He asked what is the dangerous types of oncologic emergency?
All are dangerous. That is why we call it emergency. If it is an oncologic emergency, for example, I have told you, if the patient who's superior mediastinal syndrome, if you put the patient on lying position, the patient can die. If a patient with Burkitt lymphoma, if they has a huge mass, the patient can develop acute renal failure overnight, and the patient can die due to hyperkalemia. So all oncologic emergencies are important. If the patient develops cord compression, the patient can lose his function of his extremities. The patient may not die, but he became disabled. So all are important, and we have to act equally. But based on the life-threatening condition, there are conditions like upper airway obstructions may not give you time for a few minutes or even for an hour or for a few minutes. So you have to be cautious in patients with superior mediastinal syndrome. if the patients can die. They may not give you time, but you have to consider all are equally important.
Okay, thank you, doctor. So Getachew Wonder Fresh asked, carrier bishop score for tumor lysis syndrome. If I'm not. Okay.
There's a bishop score that classifies as high risk and low risk. I didn't have the slide. I will share you with the slides.
Okay, doctor, thank you.
It depends on the uric acid level, the type of tumor, malignancy, who are at high risk for the TLAs. It is important to predict which patients are at high risk to develop TLAs.
So Asafa Sunta asked, what is the best lab investigation to oncologic emergency?
It depends on the type of the tumor. Most of the time, CBC can tell you a lot of information. If the patient, for example, has lymphoma with a lymphoblastic lymphoma, lymphoblastic leukemia, the patient can have hyperleukocytosis, and the peripheral morphology, you can see blast cells. And if you suspect respiratory distress, you can do also chest X-ray. The most important is from on the first objective I have mentioned, you have to have a hallmark science which can tell you which type of oncologic emergency is the patient is having. Respiratory distress, you have to suspect something is going on in the lung. So it can be a mass, it can be infection. But if it is a mass, the things that you can manage will be different because mass can be lymphoma, leukemia, T-cell leukemia, so the management can differ. So there is no specific investigations that can be taken as for granted. So whenever you do investigations, should be guided by the patient's condition. Your patient is a guide. Rule number one. So always follow the condition of the patient to select appropriate investigations and appropriate management. So there is no black and white investigation for oncologic emergencies.
Okay, doctor. So the next question is, how important is increased LDH to diagnose tumor lysis syndrome?
LDH is not a criteria to diagnose TLH. The importance of LDH is when the LDH is high, that tells you there is a high tumor burden, that there is more destruction of cells. So the patient is at high risk of developing laboratory or clinical TLS. So it indicates that you have to be aggressive to prevent laboratory or clinical TLS. When the patients have high LDH level, always be aggressive to prevent development of laboratory or clinical TLS. The importance is it will tell you that there is a high tumor burden and the patient is at high risk of developing TLS.
Okay, thank you. The other question by Amara Aschalo is, what common antibiotics can be used for neutropenic fever patients in primary hospitals, remote areas, till we refer them to better setup?
Most of the time, what we recommend is ceftriaxone with gentamicin can be given. So gentamicin with ceftriaxone can be started and they can be referred. Or if there is a possibility to get cefepime, you can use monotherapy with cefepime. Cefepime can be given and the patient can be referred.
Okay. So the next question is Abdurrahim Ibrahim. Is there any avoided drugs? The question is not specific, but the question is not specific. It says, is there
maybe
any
a patient who has renal failure, it is a usual thing that you have to consider that the patient can have additional renal damage if you are using gentamicin in a patient who has renal failure. If this question is like that, or if, for example, if a patient has, for example, liver problem, you have to consider drugs that cannot be excreted through the liver. So you have to see the condition of the patient.
Okay. We can answer only one question because we are running out of time, and I'll read you the last question. So, what is the duration of bowel rest in neutropenic enterocolitis?
It depends on the response. So what we do is just we will follow the thickness and the clinical improvement daily with ultrasound. If the patient responded and if the patient is stable, we can start SIPs. But some of the patients, they can be out of this condition within a week. Some of the patients can stay 2-3 weeks. There is no definite time. It is guided by response of the patient.
Okay. Thank you very much, Doctor. On behalf of Blue Health Ethiopia and all our participants, we thank you for the amazing presentation. It was a very nice presentation and important one as well. It was engaging with all the participants, and we hope we will be having more sessions like this with you, as well as the ESHO members. If you have anything at last that you want to address, let me give you the stage one more time. Dr. Abdulkadir, thank you very much again.
Thank you. Just one thing generally, what I want to mention is, in a patient with oncologic emergency, always try to save the life of the patient. The definite diagnosis is not important at that time. Anything that can save the life of the patient is any procedure, anything that saves the life of the patient is important, and you have to act immediately without wasting time. That is the most important message that I want to pass for all of you. Other things will, if the patient is alive, you'll have time for a definite diagnosis or for the next step. This is the most important thing that you have to take from this presentation. Other thing, I'll share you the PowerPoint, and you can get it from the host.
Yeah, you can send me the slides maybe on WhatsApp and
you can use it for referral, for other reference, for fast reference.
Thank you so much, Doctor. Have a good night.
All right. Thank you so much.